Bom dia a todos. É uma grande satisfação de abrir esse fórum do Corpo Clínico, hoje com um convidado distinguido na área, Dr. Christopher, que será apresentado posteriormente, e um tema para nós extremamente importante, que é o tromboembolismo venoso, a prevenção do tromboembolismo venoso nos pacientes pós-cirurgia plástica, né? Pós-cirurgia plástica. Então, eu gostaria de dizer fazer alguma introdução rápida para o professor Christopher, dizendo que a deep venous thrombosis is a preventable disease. If not prevented or treated correctly, it can rise a deadly condition known as pulmonary embolism. Even thought DVT is a well-known post-operative complication, few articles evaluate its incidence in plastic surgery. Plastic surgery may stand to benefit from well-formulated guidelines to prevent venous thromboembolism. Currently, plastic surgeons are reluctant to use prophylaxis for DVT since it is believed to increase the rate of bleeding complication. Despite of the availability evidence-based guidelines, there are still some gaps areas that need to be filled and evaluated. To address this topic, I'd like to invite Dr. Denis Valente to introduce our distinguished speaker for this morning. Please, Dr. Denis.
Thank you very much, Dr. Euler. For me, it's a great pleasure to be here and introduce one of the researchers of plastic surgery field that I most admire worldwide. Dr. Christopher Panucci is one leader in the research of venous thromboembolism, and he is also a close friend. I have the opportunity to wrote some articles with him, and it's very nice to see that we are on the same publications with your name, Christopher, and with the name of the Mãe de Deus Health System. For us, it's an honor to have you here. I would like to tell you that we are a family here, and we are very glad that you are making part of our family. So introducing Dr. Panucci, he's a plastic surgeon. He's one of the most, sorry about that, he's one of the most known plastic surgeons worldwide acting in this area, and he will present his experience with TVP. Please, Dr. Panucci, we want to hear from you now.
Great. Thank you, Dennis. And I really appreciate the opportunity to be here to speak to an entire healthcare system in an international way. So it's wonderful to see you all, and thank you very much. Gerson, I'm going to try to share my screen and make sure that we can do that. And let me do that. Let me actually start at the beginning of my talk. Great. And you can see those slides now, guys? Fantastic. Wonderful. Full disclosure, this is the only slide that will be in Portuguese, and I apologize for that, but I appreciate everybody sending me the letterhead in advance so that I could see what my title looks like in Portuguese. It's really wonderful, and it's a huge opportunity to be able to present on an international basis, to have all of us think about patient safety and how we can keep our patients healthier after their surgeries. And blood clots in the legs or lungs is one important way that we can do that. One of my big picture goals for this talk today is many people believe that venous thromboembolism prevention is a one-size-fits-all, that we should do the same thing for everyone. And one of my major goals over more than 15 years of researching this topic is to help surgeons and doctors understand that this is an individualized thing. that different patients need different things to keep them safe. In the biggest picture then, my goal for today is to convince you that venous thromboembolism prevention is more than just saying, do I give a blood thinner? Do I give chemical prophylaxis? And that it's actually taking a comprehensive approach to think about plastic surgery or surgical patients' risk for clots. Why is this important? Well, these are survey data from some of our national and international organizations that ask surgeons, what is your experience with venous thromboembolism? And amazingly, when asked the question, have you personally had a patient die from a postoperative venous thromboembolism, somewhere between 4 and 7% of surgeons have had that happen. And my hand is actually raised. I've personally had a patient die after a surgery of a pulmonary embolus. And I bet if you look around the room and maybe see some raised hands, you'll understand this is pretty common, unfortunately. Over the years, I've written several sort of bigger picture CME articles to explain this topic for the general practitioner. And this bottom one is one that I'm going to be drawing on pretty heavily, especially with this concept of 4 pillars. This is a figure taken from that article, and it really identifies different phases of care and how you as a doctor can be thoughtful about, at each step in patient's care, what can I be doing to minimize their risk for blood clots? So the first pillar is the preoperative setting, understanding before someone ever makes it to the operating room, what can you be doing to identify and modify their risk for clots? And the first one is this concept of individualized VTE restratification. In the United States, both the American Society of Plastic Surgeons and also the American Association of Plastic Surgeons have identified this idea of individualized or patient-centric risk stratification as an important patient safety tool. And the best way to do that is with this, the 2005 Capri Score. This is the most widely utilized and well-validated risk prediction tool. It creates an aggregate risk score based on the presence or absence of about 40 individual risk factors. Now, this score, the Capri Score, has been examined in plastic surgery inpatients. And it's amazing that when you look at Capri Score and rates of clots, this score can identify a 15-fold variation between your low-risk patients and your high-risk patients for 60-day blood clots in the legs or lungs. And as you look at these data, I think all of us would agree these are actionable information. You would treat people differently knowing that their risk for clots was 0.6% versus 11%. Now, this is not just to talk about plastic surgery. The Capri Score and this idea, the entire concept of individualized risk stratification, extends far beyond plastic surgery. In fact, this Capri Score has been validated to identify this 10 to 15-fold variation in risk in general, vascular, urology surgery patients, gynecology, oncology, surgical ICU, otolaryngology, head and neck. Essentially, any surgical population to which it's applied shows the same thing, that there is a wide spectrum of risk in the overall patient population. And in 2017, I took this one step further, looking at the role of Capri scoring in surgical patients as a whole. So we did this meta-analysis, and part of these data I'm showing here, looking at 6,000 surgical patients. These are all surgical patients, and showing that in all surgical populations, this score rings true, that you can identify this 15-fold variation in risk in the overall surgical population. In aesthetic surgery, which is part of plastic surgery, we've shown a similar trend. It's interesting that when someone looked at rhinoplasty patients having nose surgery, they showed that the overwhelming majority, 98% of patients, had a Capri score of 6 or less. That really tells us that our aesthetic and ambulatory and elective population is going to be at lower risk for clots. And I'm in the process of doing a similar study looking at the breast augmentation population, showing again that only about 4% of patients are even on that higher end of the risk spectrum. Now, you may be saying, well, I speak Portuguese and the Capri Score is in English. And up until about a week ago, that was true. Joe Caprini is a friend of mine. This is a kind of older picture now. It's probably about 10 years old. But Joe Caprini is a retired vascular surgeon who has spent 30 years pushing this idea of individualized risk stratification. And you can see from the dates on this email stream, just last week, I said I'm giving grand rounds in Brazil. Does the Capri Score exist in Portuguese? And the easy answer would be to say, no, it doesn't, I'm sorry. But if you look at the response from Joe, his response was, I'm having a translation made right now. So Joe actually last week had the Capri Score translated into Portuguese. And Dennis has the PDF of this and can distribute it to you so that you all can utilize this in your day-to-day without having to translate English to Portuguese. Now, once you've identified your patient's risk for clots, we are still in the preoperative setting. We are still in the clinic. And so you have the opportunity to modify risk factors that you find. When you look at the Capri Score, you can see many of these factors, like patient's weight, the type of anesthesia you're going to use, whether they're on oral contraceptives, whether they've had a recent major surgery. Some of these are potentially modifiable, especially if you're planning on an elective or schedulable operation. And really what this is doing is you're trying to make your patient as healthy as they can be before a surgery to tip that risk and benefit more toward the favor of the patient. So let's talk about a few of these individually. John Kim is a plastic surgeon in Illinois in the United States, and he published this study looking at 1.4 million surgical cases, looking at the relationship between time spent in the operating room and risk for clots. What he found is that each of these lines represents a different surgical specialty, and no matter what surgical specialty you are in, there's essentially a straight line relationship between time spent in the operating room and risk for blood clots. That means that operating room time is a potentially modifiable risk factor. This is another study from Julian Winnicor in Tennessee in the United States, looking at 129,000 cosmetic surgery patients, showing that when you combine surgeries, when you add additional procedures, you increase your risk. And again, this tells us that there's an opportunity here to say, should I minimize my time in the operating room to minimize my patient's risk for clots? Now, this is a picture of Dennis, of course, but long before I met Dennis, long before we did research together, I found this article. This article is almost 10 years old now. And this is a wonderful article looking at estrogen, a potentially modifiable risk factor in aesthetic surgery patients. And this comes out of your fine institution. So here it is. I'm using your own research to teach you, which is fantastic. And Dennis looked at the role of hormone use, like estrogens, in cosmetic surgery patients, and clearly showed that when patients are taking estrogens before surgery, it increases their risk for clots. So you can take patients off their estrogen in an elective setting to further minimize that risk for clots. And in fact, thinking about the gender confirmation surgery population, other authors have said surgeons can engage patients in this joint decision-making process. There are risks to your estrogens. There may be benefits to your estrogens. How do you feel as a patient about coming off of them for an elective surgery? Now, plastic surgery tourism. People fly to have their operations, not just for plastic surgery, but for all surgery. And I think it's important to understand sitting in coach for 8 hours and not drinking enough is a risk factor for clots, and that's been shown. This wonderful study, these researchers actually brought an ultrasound machine into the airport, and they scanned the legs of people who were getting on a flight going across the Pacific Ocean. When they got to their destination, they scanned them again, and they showed that many people, about 5%, had an asymptomatic blood clot in the legs that developed during the flight. In a subsequent study, they randomly assigned people to wearing compression stockings or not, and they showed that compression stocking can bring your risk from 1 in 20 to about 1 in 400. And so wearing compression stockings, staying hydrated on flights, is another way to minimize clots. Now, since we're still in the clinic, since we haven't done an operation yet, you can identify patients at higher risk for clots. And for example, if someone has a known genetic mutation, if they have a family history or a personal history of clots, you might consider referring them to a hematologist or some other person that can better evaluate them to help to better identify their risk. And also for women, I ask everyone about this. Have you lost multiple pregnancies? And it's about one woman in 10 who has unexpectedly lost 3 or more pregnancies. And that can be a marker of an unrecognized genetic hypercoagulability. And finally, this information guides how I interact with my patients in the preoperative setting, because I'm now able to provide a data-driven approach to understanding their risk for blood clots. It allows me to provide a percentage risk when available to say your risk is 1 in 100 or 1 in 10, and also to modify risk specific to that elective surgery population. And this information is important when you're talking about, should we do 1 procedure or 2? Should we do 1 3-hour operation or 1 6-hour operation? It helps you to talk about patient safety. And for that very high risk patient that you identify, you also might say, listen, I don't think it's safe to do your operation at all. And now you bow out and not do the surgery in the preoperative setting. So moving forward to the operating room, right? We've now identified and modified our patient's risk. We've gotten them as healthy as possible. In the operating room, there are additional things that we can do to further minimize risk for clots. Anesthesia type is a recognized risk factor for blood clots in the legs or lungs. And these are meta-analysis data from the American Association of Plastic Surgeons that clearly showing, when possible, avoiding a general anesthetic can protect patients from blood clots. And specifically, the society recommended using a non-general anesthesia when appropriate. Now, I acknowledge there are surgeries that cannot safely be done under a non-general anesthetic. There are also facilities that don't have access to these techniques, but when it's available, consider it, because it can decrease your patient's risk for clots. Now, intermittent pneumatic compression, sequential compression devices, you guys have these as well. These work in 2 different ways. Number 1 is they physically propel the blood up and out of the legs to minimize stasis and venous dilation, but they also activate the local fibrinolytic system. So your levels of bloodborne fibrinolytic factors will go up when a sequential compression device is in place. So they work in 2 different ways. And it's clear, these are meta-analysis data from surgical patients as a whole, that wearing sequential compression devices can decrease your risk for blood clots in the legs. And that's why the American Association made a very strong recommendation that intermittent pneumatic compression should be used to prevent blood clots, specific to the plastic surgery population. Now, we started talking about this already, the role of operating room time and clot risk. So balancing multiple procedures with patient risk for clots. Patients always want everything done at one setting because they want to have 1 surgery, 1 recovery, 1 set of restrictions. But while that's good for patient convenience, it may not be good for their safety. Again, going back to this paper showed that when you combine procedures, looking at the right of the graph, your risk for clots is much higher than when you do isolated procedures on body areas. You may look at this and say, well, 0.3%, 1 in 300 is an acceptable risk, and it may be, but it's still something that you should discuss with your patients, that adding procedures of the breast and body, for example, will increase your risk versus a breast procedure alone. This is another study from breast augmentation population, again showing on the right side that combining a breast augmentation with another surgery increases your risk by a factor of 5. To be fair, it increases your risk from a fraction of a percent to a slightly higher fraction of a percent, but these are still things to talk with your patients. Placation. Abdominal wall placation is something that we do in tummy tuck surgery. It's also something that is done in breast reconstruction and in hernia repair, for example. It's important to look at the role of placation as a potentially modifiable risk factor for clots. When you tighten the abdominal wall right to left, you will increase the pressure on the inside of the abdomen. And studies have shown that when the abdomen is plicated in abdominoplasty, your intra-abdominal pressure goes up by about 6 millimeters of mercury. And in pedicle tram breast reconstruction, it goes up by about 12. Now, why is this relevant? Well, a higher pressure inside the abdomen will put pressure on the inferior vena cava, and it can create problems with blood getting out of the legs, creating a situation of stasis where blood clots can form. This is a study from Arash Momeni at Stanford looking at flow in the common femoral vein in the leg in response to plication. And what Arash showed, this black bar is the common femoral vein diameter. And what he's showing is that between the preoperative and then the recovery unit and post-op day number 1, the blood vessel diameter gets bigger and bigger after plication because that tightening of the abdominal wall is creating lower extremity venous stasis. And the gray line looks at the internal jugular vein as a control. That the internal jugular vein does not do this as well. It's not from the fluid received in surgery. It's from what happened in the surgery with the abdominal wall plication. So, should I not combine procedures? Should I not plicate? Well, no, I'm not saying those things at all. These are all things for us as physicians to understand so that we can have a more thoughtful conversation with our patients about risk for blood clots and what we can do to minimize but never eliminate that risk. Now, we are leaving the operating room and we're getting to recovery, probably the shortest time point or phase of that patient's care. But even in the recovery room, there are things that we can be doing to minimize their risk for clots. Early ambulation, up and walking as soon as possible, is a way that you can reactivate the patient's calf muscle pumps and get the blood circulating again. Stasis is a main component of Virchow's triad, and getting up and walking can minimize stasis in the lower legs. Avoiding dehydration, right? We all know that if your blood is thicker or if you are dehydrated, it is going to be more likely to clot. This is a study out of Salt Lake, Utah, in the United States, where they were talking about the role of hydration after surgery. And for 450 consecutive abdominoplasty patients, this surgeon admitted everyone overnight, kept a very close eye on their urine output, and was actively giving them fluid boluses if their urine output was low. With that fairly aggressive technique, the risk for clots in 450 abdominoplasty patients was around 1 in 400, which is quite low. And their conclusions were really important, that hydration and lower extremity elevation are essentially risk-free adjuncts to better improve your patient safety. Now, still in the PACU, coming back to the intermittent pneumatic compression. In the PACU, the intermittent pneumatic compression can take the role of the calf muscle pump until someone is up and walking. And we talked about how these work already. And finally, evaluating garments. For those of you that use abdominal binders after an abdominal surgery, for those of you that use garments after liposuction or other slimming procedures, those garments can create problems. And this is a study where surgeons placed garments on patients and then did ultrasound to look at the common femoral vein. So here what you can see is before on your left and after the garment is placed, the popliteal vein behind the knee gets bigger. And that's telling you that upstream in the thigh, the garment is actually creating a constriction point and creating that situation of lower extremity venous stasis. They looked at different tension points in the garments and showed that actually cutting the garments can decrease those tension points. And just 2 weeks ago in my own patient in the recovery room, I slid 2 fingers under her thigh portion of the garment and said, wow, this is really tight. And so I took a scissor and cut that garment just like these pictures to minimize that risk. So this is something that I do in recovery, checking that garment to make sure it's not overly tight. Should I not use garments? Well, no. I think using garments, using binders is completely fine, but you need to use them in a thoughtful way. Again, this gets back to talking to your patient in advance about things I'm going to do and how I'm going to take care of you. So we're now moving out of the recovery room and we're moving toward either discharge from the hospital for your day patients or admission to the hospital for your overnight stay patients. In the post-operative setting, early ambulation when possible and avoiding dehydration are still appropriate, just like they are in the recovery room. Compression stocking. So my patients travel up to 3 or 4 hours by car or rarely by plane to come see me. And for those patients, we've talked about the role of wearing compression stockings in long travel as an additional way to potentially minimize patients' risk for clots. And finally, after discharge anticoagulation or blood thinners, based on your patient's own personal characteristics and what their risks and benefits are. Now, way back a half hour ago, I said that one of my goals was to help you as physicians to understand that preventing blood clots is more than just, do I give a blood thinner or do I not? And in support of that statement, this is slide 75 of this talk, and it's the first time that I've mentioned blood thinners. And I think that that really proves the point. There are many, many things that you can do to keep your patients safe and minimize the risk for clots that do not involve blood thinners. But people always ask about blood thinners, so let's talk about them. The Plastic Surgery Foundation is the research arm of the American Society of Plastic Surgeons. And in 2008, the Plastic Surgery Foundation funded this VTEPS study based on concerns raised by the membership that we need data from our specialty to help keep our patients safe. The Plastic Surgery Foundation put together a 4-hospital network of major teaching institutions in the United States to do this study. Now, over a 4-year period, those 4 centers enrolled over 3,300 patients. Some of those were patients that were historic controls who received no blood thinners after surgery, and some of those were patients that received postoperative enoxaparin, which is a blood thinner, a low molecular weight heparin, for the duration of their inpatient stay. Now, these are the data looking at 3,300 plastic surgery inpatients. And when you look at the red bars and the blue bars for low-risk patients, you can see blood thinners really did not make much of a difference. And this cut point of Caprini of 6 or less is really going to be important as we continue this discussion. But when you start to look at those higher risk patients, patients with a Caprini score of 7 to 8, or patients with a Caprini score of greater than 8, you can see that those blood thinners really made a difference, decreasing risk for clots by 1.5% to 4.5%. Now, to be fair, when we looked at these results with statistics, these differences were not significant, but there's multiple factors at play. And so just like Dennis did in his study of estrogen use in cosmetic surgery patients, we use the same statistical technique, a multivariable logistic regression, to compare or to control for other factors. And we found that when controlling for length of stay and baseline Caprini score, that receiving a postoperative blood thinner was protective against postoperative blood clots with an odds ratio of 0.39 and a p-value of 0.042. It's important to be skeptical about the research that's out there. And so if only one person says something, maybe you wait for more information. Well, flashing forward, this paper came out a few years later that was an independent confirmation out of Japan of these results. And you can see the results slide that they independently identified Caprini scores of 7 to 8 and greater than 8 as being at higher risk for postoperative blood clots than the overall plastic surgery population. So multiple places, multiple countries are showing that this paradigm is correct. So as an interim summary, there's clinical trials data, international clinical trials data, that supports providing blood thinners for Caprini 7 and higher plastic surgery inpatients. Now, blood clot prevention is only half of the story. We have to think about risk for bleeding, as was mentioned in the lead up to this talk. This is a meta-analysis looking at 33 randomized controlled trials, and they showed that in the surgical population as a whole, patients who receive blood thinners go back to the operating room for bleeding less than 1% of the time. In the VTEPS data, we also showed this to be true. Patients that received a postoperative blood thinner had about a 0.7% higher risk for blood clots, or one patient in 150 that went back to the operating room more frequently. And when we did the regression, interestingly, receiving a blood thinner was not predictive of going back to the operating room, but surgeries of a larger area, like breast surgery and microvascular surgery and post-bariatric body contouring, were independent predictors of bleeding. Now, I put this study up there earlier. This was in response to the VTEPS data and trying to take this to the next level of saying, well, we know that this happens in plastic surgery patients. What about surgical patients as a whole? So I utilized a methods person from the Cochrane collaboration, arguably the international leader in meta-analysis, to look at this question of, does the Capri score identify patients, surgical patients as a whole, who benefit from blood thinners? We looked at 11 years of abstracts and found 13 manuscripts, including almost 15,000 surgical patients as a whole. 4 of these were plastic surgery, 9 of these were general surgery, or ENT or OB/GYN. Now, this is a forest plot looking at the role of blood thinners in lower risk patients, Capri 3 to 4 and 5 to 6. And if you have looked at forest plots before, you know that if the black diamond touches that vertical line right in the middle, it means that the result is not significant. What these data show you is that looking at almost 10,000 lower risk surgical patients, postoperative blood thinners do not decrease risk for blood clots, and this is important. However, when you look at higher risk patients, surgical patients as a whole, with Capri scores of 7 to 8, blood thinners do significantly decrease risk for blood clots. And similarly, with higher risk surgical patients, Capri scores over 8, blood clots do significantly decrease risk for clots. And this is important because when you look at all patients, if you give anticoagulants or blood thinners to all patients, you will increase their risk for bleeding. These are updated data looking at surgical patients as a whole who receive anticoagulants, and you can see at the bottom, when you do provide anticoagulants to everyone, you will increase the risk for bleeding. And this really supports that you should only provide blood thinners to the patients that you intend will benefit, i.e. those patients with Capri scores of 7 to 8 or greater than 8. So that meta-analysis clearly shows not only in surgical patients or in plastic surgery patients, but in surgical patients as a whole, the only patients that we clearly know benefit from blood thinners are those with Capri scores of 7 to 8 or greater than 8. And this is important because if you anticoagulate everyone, you will increase the risk for bleeding. So I believe that those clinical trials data show that clinical trials and meta-analysis data support providing blood thinners only to those patients with Capri scores of 7 or higher to balance that risk of preventing blood clots and also minimizing bleeding. Now, it's interesting that some aesthetic surgeons doing cosmetic surgery, they anticoagulate everyone. And I give talks like this at our national meetings and at international meetings in venues like this one on a regular basis. And it's really common for people to come up to me and say, listen, I understand your data, but I don't want to have that risk, that liability, so I give a blood thinner to everyone. Well, is that safe? Well, these are data looking at facelift patients, showing that routine anticoagulation of facelift patients is not safe. If you give enoxaparin, a low molecular weight heparin, to facelift patients, and you start that medicine before surgery, 16% of patients will bleed. I don't think that that is a safe bleeding risk, and so I would not suggest doing this for facelift patients. This is a study out of New York that looked at giving all abdominal body contouring surgery patients blood thinners, and they showed that it didn't substantially decrease risk for clots, and it did potentially increase risk for bleeding by about 1.5%. Another study looking at rivaroxaban, an oral factor Xa inhibitor, and giving that routinely to abdominoplasty or tummy tuck patients. These surgeons are giving it to everyone starting 12 hours after surgery and continuing it for 1 week. And they showed that when you do that, the expected risk for clots is around 0.75%, one patient in 130, and the risk for bleeding was around 4%. For me, as someone who does tummy tucks regularly, that risk for bleeding feels pretty high. And while this study doesn't have enough patients to say it definitively, I think that these data really support not giving it to everyone because it probably increases the risk for bleeding in patients who wouldn't necessarily have a benefit. Another study out of St. Louis, Missouri in the United States, looking at routine provision of fondaparinux, which is another blood thinner, actually showing that there was a significant difference. And Herlef Lund is the past president of the Aesthetic Society in the United States. This paper did show that giving everyone fondaparinux, a blood thinner, after body contouring can reduce risk for clots. They did not show that it substantially increased risk for bleeding. So there are lots of data out there about both the risks and benefits. Now, people always say, listen, what I really want to know is, what do you think? You've been doing research in this area for 15 years. What are you doing for your own patients? Well, here's an excellent example. This is an in-progress study, not yet published, where I did Capri risk stratification on 100 consecutive breast augmentation patients. These are patients who are typically young, fit, healthy, and having an outpatient surgery. When I did that, I showed that only 4% of the breast augmentation population has a Capri score of 7 or higher. And we've previously shown that that is the cut point where chemical prevention can be impactful. And this is an article I wrote in response to a similar paper on rhinoplasty, and the title really states my position from 5 years ago, and I still believe that this is true, that the vast majority of the aesthetic surgery population are at low risk for blood clots and do not require anticoagulants. This is a long talk, and I hope that everybody has been able to keep up with the English to Portuguese translation. But again, the big picture points of this talk that I really want you to remember is that blood clot prevention in plastic surgery patients or blood clot prevention in surgical patients is not a one-size-fits-all mentality. You should identify your patient's risk as individuals, and you should treat patients differently based on their individual risk for clots. And this concept, this idea of the 4 pillars of considering patients' risk in advance, modifying and eliminating risk factors as much as possible prior to surgery, being thoughtful about the risk for clots in the preoperative, in the intraoperative, in the postoperative, and in the post-discharge setting can help to keep your patients safe. Ultimately, I don't think that we can ever eliminate risk for blood clots, but we certainly can minimize it. And my goal today is to help you to understand how can we minimize your patient's risk for blood clots and keep them as safe as possible. I really appreciate the opportunity to spend about an hour with you guys today. Dennis, I really appreciate the opportunity to come in and speak on an international stage and to a health system that I was told has 2,300 physicians and 7 sites. What an opportunity for me to be able to educate. My email is on the screen. You're welcome to reach out via email, via Instagram, if you have questions or concerns. Dennis will hopefully find a way to distribute the Capri Score in Portuguese for you so that if you'd like, you can use that. And I intentionally stopped this talk a few minutes early. I know that we have another 10 or 15 minutes, and I'd be happy to take any questions. Thank you, and I'll take any questions now.
Thank you very much, Dr. Panucci. Podemos ter a imagem do Dr. Panucci aqui na tela, por favor? Can you please stop sharing your screen and show you at the screen, please, Dr. Panucci?
Yep, I will do that. 1 second.
Thank you very much. I would like to give you a background here. We did a protocol of prophylaxis something like 12 years ago. Dr. Euler is one of the most brilliant cardiologists here in Brazil, and he did this protocol for us. And now seeing your lecture, seeing your work, you know that I am a big fan of your work. Dr. Euler just told me that we will have to review our protocol, so your lecture gave us a lot of things to think and a lot of things to improve to give more safety to our patients. Thank you very much. The question that I would like to make for you, for first, is about, I don't know if in USA the physiotherapists are using kinesiotapes instead of garments, compression garments in the post-operative time of liposuction, this kind of surgeries. I don't know.
Interesting. No, you know, we are not routinely using kinetic taping instead of garments. In my own personal practice, we are 6 plastic surgeons at Plastic Surgery Northwest. We do a high volume of aesthetic surgery, and for us, when patients are having liposuction of the hips or flanks, when patients are having tummy tucks, we are typically using a garment that goes from the ribs to the mid portion of the thigh. We are not using kinetic tapes. I don't know of a lot of my colleagues in the United States that are using that either.
Okay, thank you very much. I will give the word to Dr. Euler that will talk about your lecture. Thank you very much, Dr. Panucci.
Thank you.
Dr. Panucci, terrific speech. I'd like to, can you address about to implementing protocols in post-operative in plastic surgery in a general hospital, please?
Yeah, it's a lot of work to answer your question. So that study that we did, the VTEPS study, one part of it that I did not discuss today was the implementation component. And it is a challenge to implement these sorts of things on a hospital-wide level. It takes a concerted effort on everyone's part in order to say, listen, we are going to make this a priority and we are going to do our very best. When we were implementing this at the hospital level, we had many meetings to talk about the status of the current literature, why this is important, and to get buy-in not only from the surgeons but from the residents at the facility, from the nursing staff, from the pharmacy staff, working to figure out how can we implement this on a hospital-wide basis. And we actually tracked compliance with the protocol over a 1-year period, showing that a combination of directed education, of journal clubs, of regular email reminders, and a myriad of things can slowly increase the rate of compliance at the hospital level. So you're correct that you just can't decide one day, we're going to do this. It takes an effort on behalf of the entire healthcare system. And when we did it, when I was at the University of Michigan, it was a 6-month lead up of getting everyone on board with this protocol and prepared.
Thanks a lot. Dr. Panucci, thank you very much for your presentation. Here is Cristiano Jäger speaking. I'm a clinical cardiologist here in Mandeus Hospital. It's been 20 years I've been working here with post-operative patients. And most of our, as we work in hospital, most of your patients are outpatients. So we have a few plastics patients here. Those patients which we have Capri 7 or more, those 4 or 5% of your patients that we have to use chemoprophylaxis, I'd like to ask you about the time of using the heparin. I see some surgeons have some concerns about using 1 or 2 hours before surgery because of bleeding, obviously, and
Yes.
especially when you have spinal anesthesia. How about the time you usually recommend?
Yeah, this is a great question. So when enoxaparin or Lovenox initially was doing the clinical trials to get approvals, they were using a very aggressive protocol, giving that medicine an hour or two before surgery and then continuing it afterwards. I think that there are now a lot of data that suggests it may not be beneficial. Like I don't know of any data that say giving that medicine before surgery is any better than starting it after surgery. But there are definitely data that say when you start the medicine before surgery, you do increase patients' risk for bleeding. When I'm using that medicine, first of all, as a surgeon, I'm making the judgment to think, how did the operation go? Am I concerned about bleeding? And clinical judgment will always be first. So if you as the surgeon say the operation was very bloody, I'm worried about this risk for bleeding, it is totally appropriate to withhold, to not give a blood thinner until you think that bleeding risk is appropriate. For the general inpatient, I've done clinical trials where we're giving it as soon as 7 to 8 hours after surgery. I've done clinical trials where we're giving it the next morning. And there is definitely a balance. I know that when you give the medicine between 7 and 8 hours after surgery, your expected bleeding risk is going to be around 5%. And some of those bleeds are maybe not clinically relevant. Maybe the drain output is bloodier, or maybe you take them off the medicine, but some of them require transfusions or going to the operating room. So I think that the earliest that I would recommend giving it is 8 to 12 hours after surgery. But that needs to be a decision made by the surgeon based on how things went in the operation. I think that seeing the patient the next morning and looking at their drains and seeing how they're doing, that's also appropriate if you're concerned that the operation was very bloody. Specific to that VTEP study, the goal timing for the blood thinner was within the first 24 hours after surgery. And again, that gave surgeons the flexibility to understand where the bleeding risk was and maybe even evaluate their patients once after surgery to say, is this a safe timeline? And the best data about how long to give it, unfortunately in plastic surgery, the best data say to give it for the duration of the inpatient stay, because that's what the VTEP study did. There are other studies that suggest giving a longer duration of anticoagulant after patients leave the hospital may be impactful. In plastic surgery, we don't have any data that support that's true.
All right, thank you very much.
So, Dr. Panucci, I will let the audience know if someone has some question. I will ask in Portuguese.
Please.
Alguém teria alguma pergunta para fazer para o Dr. Panucci?
Thank you, Dr. Panucci. I'm a vascular surgeon. The first time I attend a presentation, a plastic surgeon with this issue. Very surprised for me. Very nice, your presentation. And my question is, when say no to the patient with Capri high risk? Difficult. Thank you very much.
Sure. Your question is, when do you say no to a patient? Did I hear that correctly?
Yes, that's it.
So it depends on the operation. I do the broad spectrum of plastic surgery. And so if someone comes to me for breast reconstruction after cancer, if someone comes to me for limb salvage with their tibia bones sticking out of their leg after a car accident, or if someone comes to me for a tummy tuck, my answer would be different, quite honestly, because the severity of the injury and the time-sensitive nature of the surgery is different in all those cases. For patients with an urgent need for surgery, like a car accident where the option is amputation or limb salvage, I will still have the conversation with the patient But even if someone is higher risk, I will almost certainly still offer them an operation, because to withhold an operation commits them to an amputation, which is potentially avoidable. So the risk and benefit is different. For my breast cancer patients, if someone has a very high risk for clots, knowing that surgery puts them at higher risk, knowing that cancer puts them at higher risk, sometimes I will still offer them surgery. Sometimes I will say, get through your cancer care and come back when your cancer care is complete, because that allows me to do maybe a smaller operation, or an operation when the chemo port, the vascular access device, is out, when your cancer has been treated, and when you are head to toe healthier. And so those patients, maybe I do their operation now, maybe I wait for a year. For my high risk, if someone came to me for a tummy tuck and they were high risk, I might just say no. Sometimes I will still send those patients to a hematologist, have them worked up for bloodborne genetic hypercoagulability, and then bring them back to have a discussion. But if someone has a genetic reason that they clot more than most and a personal history of blood clots, I will definitely discuss no operation with them. But I might also discuss other paradigms. I had a lady just a month ago who had a personal history of blood clots in pregnancy, and she wanted a breast augmentation. And what we agreed on was that I would do her breast augmentation under IV sedation and no muscle relaxant, as opposed to a full general anesthetic. And that helped to decrease her risk for clots while still having her have an operation. So I think the decision to say no is not only based on a Capri score, it's also based on the patient's goals and their own personal circumstances, because my willingness to do an operation is different depending on why someone needs that operation. Again, it is very much a patient-centric balancing risks and benefits of the surgery. Thank you for your question.
Dr. Panucci, my name is Cícero Baldin. I'm a cardiologist here in Hospital Mãe de Deus. And I'm here because I was involved in the implementation of the protocol of thromboprophylaxis here in the hospital. And the patients that had ambulatory care were the most difficult for us to access. We put the Capri Score. We did a translation here, not allowed by Dr. Caprini, but we did a translation, and we put on our system of the hospital. But the patients that were in ambulatory care, we didn't have the chance to get this done. And even in other patients, do you have any tips that we can minimize the variation of care?
Yeah, it's a great question, thinking about the ambulatory patients. And I think in 2022, there are lots of data supporting the role of Capri risk stratification and using that score to determine how you're going to provide care for the inpatient population. For the outpatient population is harder. The Capri score has absolutely been validated in the inpatient population, but the validation in the outpatient or ambulatory or elective population is still ongoing. And that's for two reasons. One is the outpatient population, by definition, is a highly selected population. They are patients who are usually young and fit and active, and people that you as a surgeon or you as a clinician believe are healthy enough to go home right after surgery. So we are automatically picking that low-risk group and sending them for ambulatory surgery. Those patients have a known very low risk for clots. Data from the United States suggests that clot risk is 0.09%, or like a 1 in 10,000 patients, which is wonderful if you are one of those patients, but which makes it very difficult to study. The way that the Capri score is known to be useful for the ambulatory population is to identify those higher risk patients. And not that you can, if someone has a Capri score of 10 and they're having an outpatient surgery, you don't know the percentage risk that they have, but you do know that they are at higher risk than most. And it might prompt you to be more thoughtful about their care and how can I minimize their risk for clots around the time of surgery. Frankly, the validation studies for the Capri Score to actually look at, providing an anticoagulant to Capri greater than 8 outpatients is going to be very hard to do because their expected risk for clots is so low. But that's the best information that's out there right now about the Capri Score in the ambulatory population.
Thank you very much, Dr. Panucci. I would like to tell you that we are a Catholic institution here. And before your lecture started, I was talking with our president, Sister Lucia. She told me that she will watch about 10 minutes of your presentation, but she remained until the end of her presentation. I'm looking at her here now. And I think that I know where I'm going to find money to give you here, to take you here personally. So thank you very much for your time. I appreciate it a lot. You gave us a lot of information, and I think that our patients will feel safer with the protocols that Dr. Euler and the cardiologist team will work now. Just a second. Dr. Cremonesi will talk to you now.
Great. Thank you. Thank you.
Cremonesi, may I do a last question, please? Do you know any evidence of using a factor 10A inhibitor in preventing VTE in plastic surgery?
Yeah, so those final slides that I showed looking at blood clot prevention in the abdominoplasty population, there are more and more surgeons that are using the oral factor 10A inhibitors. Patients love it, right? Because it's an oral medicine, it's not a shot, which is wonderful. There are many more data on enoxaparin, an injectable low molecular weight heparin, than the oral medicines. The best that I can tell you is that in a study, for example, of 600 consecutive abdominal body contouring patients, there's a surgeon, Joe Hunstad, who gave all of his patients an oral 10A inhibitor, rivaroxaban. And they showed that the risk for clotting was low. I think it was 0.5 or 0.7%. And the risk for bleeding was low, around 1 or 1.5%. So as more and more data become available with those, I think right now we can say that those medicines seem like they're safe. They don't increase the risk for bleeding any more than the blood thinners that are injectable, but we don't have enough data to say, are they effective, right? So for me, it still doesn't make sense to give every patient an oral medicine just because it's easier, because that medicine is not proved to be impactful. And so until we can show that that medicine decreases risk for clots in the tummy tuck population, I'm certainly not giving it to everyone. There are more and more surgeons who are, and I look forward to seeing those data because I think that it will help us to better guide our decisions in a data-driven fashion.
Thank you. I completely agree.
Any other question? So, Dr. Panucci, I'd like to really thank you for your very well-based talk, but also with a really practical approach that's really, really good. And the beauty about the online is that we can bring such a good speaker to be with us in our forum. Thank you very much.
Thank you very much. I really appreciate the opportunity to spend an hour with you guys today.
My name is Rafael Cremonesi. I'm a critical care physician, but currently I'm the CEO of the organization. And I'd like to address you, Dennis, and thank you for being a leader in your plastic surgery. And it's my obligation to say that for us in Mãe de Deus, plastic surgery is a pillar for the health, even though maybe sometimes only the aesthetic proposition is confounded with futile. We know here that the integrity of the patient concerns pretty frequently the aesthetic purpose of the surgery. We are engaged in duplicate our the number of our rooms for plastic surgery in your ambulatory or your day hospital. And we are doing that with a group of physicians, and with them is your fellow Dennis. I'm pretty sure there will be an opportunity for you to visit us here and contribute to the committee that's developing the plastic surgery in Mãe de Deus. So the message for the organization is that plastic surgery is a big deal for us in Mãe de Deus. Thank you, Dennis. Boa tarde, então, a todos. Thank you, Panucci.
Thank you all. Hello. Great. Yes, and thank you very much for your help today. Have a great day. Okay, bye-bye.